So we are discussing about hyperaldosteronism. Hyperaldosteronism. So this is the adrenal gland, and you have the cortex, glomerulosa, that is general manager. Glomerulosa is secreting mineralocorticoid aldosterone, responsible for sodium water retention. So the most common cause is bilateral adrenal hyperplasia. That means in both sides you have. Now another cause is adrenal adenoma, that is Cone syndrome. So both these are, there will be increased secretion of aldosterone, means it is primary. Another case, there is decreased blood flow to kidney, decreased GFR. For example, there is fluid in the third space, like in ascites. Ascites is present, like in congestive heart failure or in nephrotic syndrome, like that. So in that case, there will be secondary aldosteronism, that is RAS mechanism is activated and then aldosteronism in ascites. So these are the causes. Causes can be divided into secondary, so here directly they are producing in adrenal adenoma, and bilateral they are producing aldosterone. So this is primary, this is secondary. This is secondary because you have RAS mechanism activated. So in primary it is renin low hypertension, here it is renin high hypertension. Secondary is called renin high renin hypertension. So the clinical features will be, it's very easy. Clinical features, aldosterone will cause sodium water retention, therefore it is causing hypertension. So hypertension clinical manifested as headache, can be a resistant hypertension, because as usual if you are treating with resistant hypertension definition, you are giving 3 classes of drugs and one of the class is thiazide diuretics. Another thing is, because of the aldosterone there will be secretion of potassium and H+, so that is called metabolic alkalosis. Another important point, there is no edema. Why? Because all the water is collected in the blood vessel, increased intravascular space, so more venous return, all this fluid is reaching back into the heart. See, more fluid collection is occurring, and all more fluid is collecting, isn't it? Intravascular space is increasing, so the fluid reaching to the heart is increasing. So there is something in the heart called ANP, atrial natriuretic peptide, it is activated, so there will be natriuresis. That is the reason why you have no edema, means all that is urinated out. So investigations, when there is a tumor you can do CT abdomen. Okay, the tumor is in the abdomen. Then next, serum levels of electrolytes, ABG. Then in potassium you can go for ECG. So potassium decreased, TY will decrease. Is proportional. Okay. So what is the DD of Cone syndrome? Cone syndrome means this here adrenal adenoma. This is Cone syndrome. So another thing you have similar condition, gain of function of epithelial sodium channel where there is increased sodium water. That is Liddle syndrome. So in Cone syndrome, you have increased aldosterone, so it is activating ENaC and increased sodium water. In Liddle, it is starting from here. That is gain of function of epithelial sodium channel. There is no aldosterone mechanism, but it is starting from here. So what is the treatment? Spironolactone, potassium sparing diuretics. Especially in this case, spironolactone, because third space in this tumor you can do surgery. Adrenalectomy can be done here, adrenal adenoma. First you correct with spironolactone, then surgery. So this is hyperaldosteronism causes, clinical features. Why no edema? Okay, why no edema? What is the differential treatment? Okay.